Welcome to this video on the bee-free orthokeratology lens system. My name is Randy Kojima, and this session has been brought to you by Precision Technology and Cardinal Contact Lenses. Now, there are two labs in Canada that you can access the bee-free lens, Precision Technology in Vancouver, BC, as well as Cardinal Contact Lens in Cambridge, Ontario. So that gives access to Canadian practitioners from coast to coast and north to south. Orthokeratology is a treatment that is well accepted globally as a myopia control tool to slow down eye growth. Of course, there are others as well, like soft multifocal lenses, and more recently, specific ophthalmic lenses have been created for glasses to reduce the axial growth in kids. However, orthokeratology has had the longest history and the greatest volume of publication related to its use for myopia control. This study by Maria Liu was a meta-analysis of all the publications that they could find related to orthokeratology, going all the way back to 1980 and up to 2015. As a Chinese-trained ophthalmologist, and obviously as a Chinese speaker, Dr. Liu was able to go through both the English publications as well as the Chinese publications. So that gave us 170 that met the criteria for the meta-analysis. And in her findings, she noted there's sufficient evidence to suggest that Ortho K is a safe option for myopia correction and retardation. Long-term success of Ortho K treatment requires a combination of proper lens fitting, rigorous compliance to lens care regimen, good adherence to routine follow-ups, and timely treatment of complications. So obviously many things that make sense to a practitioner who's very careful in how they approach contact lenses in practice, and certainly approaching contact lenses in kids. Now, why would you choose the bee-free lens? The bee-free has been designed and developed by the CAT Design Group. That's made up of some names that are pretty well recognized in the industry. Bob Heaviside as president with a lifetime in contact lens manufacturing. John Mountford, who's probably the person in orthokeratology known around the world today. John has published numerous studies on Ortho K treatment to help us understand how it works, why it works. Then, of course, he's the gentleman who wrote the textbook on orthokeratology that's considered the Bible related to this treatment. Patrick Caroline is well known across the planet as an educator, a researcher, and clinician. He's probably one of the most well-known lecturers around the world. And then Dave Barretto is the software engineer that does most of the coding of the various designs. And then, of course, myself. So the group designs and develops many lenses, scleral lenses, corneal GP lenses, and so on. But specifically in this case, the bee-free lens is one of the most recent that the group has developed and licensed to Precision and Cardinal in Canada. Now, an important understanding in Ortho K is that virtually all the designs are manufactured as a 6mm optic zone. And they are designed that way because Ortho K lenses were originally created for adults, and that was to provide a reduction in their myopia over the course of the day so that they were free of glasses and contact lenses. So that 6mm optic zone was chosen because that gives the most consistent treatment as well as quality vision for most patients from AM to PM. So 6mm optic zone is pretty standard, and that's provided us with a very good outcome for the adults that we fit in Ortho K. Now, from the beginning of the modern ortho-K, of reverse geometry ortho-K lenses, it's been understood that they increase high-order aberrations. The last three studies here, the Quiros, Hirooka, and Chen study, all show us that the higher the high-order aberrations, the lower the axial growth in kids. So we've known that high-order aberrations exist in adults, but in children, the more we increase the HOAs, namely the spherical aberration as well as the horizontal and vertical coma, that helps to reduce axial growth. Now, in children, we know that in the larger the treatment zone, the lower the add power in the pupil, as well as the lower the high-order aberrations. As we decrease treatment zone size, we increase the amount of plus power distributed within the pupil, and that increases the high-order aberrations. And as we said previously, the more we increase high-order aberrations, the better the myopia control. So smaller treatment zone, creating more plus power in the pupil, creating high order or an increase in high order aberrations, we get better myopia control. Now, there's another way to look at this. The Zhang study and the Yan Yuan study showed us that the more plus power that's created inside the pupil with Ortho-K, the better the myopia control in kids, as well as increasing spherical aberration. The Hirooka and Lau study have told us that increase the spherical aberration and you decrease the axial growth. So the combination goes very much together. Small treatment zone, creating high plus power inside the pupil, which also creates increased spherical aberration and increased aberrations. That decreases eye growth. So if we were fitting an adult with orthokeratology, of course, we'd want to use the largest optic zone possible to reduce the aberrations, to create the least disruption to quality of vision. That means that we want a big treatment zone and a limited amount of power change within the pupil. We want this big treatment area creating a low amount of plus power. That will create the best quality of acuity for our adult patients. However, for kids, we don't want the large optic zone lens creating the large treatment zone. We want to use a smaller optic zone, creating more plus power within the pupil and increasing the aberrations. So that creates the outcome you see here: smaller treatment zone, more add power within the pupil, and the associated increase in high order aberrations. So there are two very different approaches for fitting the adult or fitting the child in orthokeratology. And the B-Free allows for both of these constructions: larger optic zones for adults, smaller optic zones for kids, ideally creating the type of reduced aberrations in adults and the targeted high order aberrations or increased aberrations in kids. Now, the B-Free lens is not only a lens, it's also a fitting software and support system. So you have both lens, a fitting platform that aids you throughout the entire fitting process, as well as consultation and support from the lab. So this could be considered a very complete system for approaching orthokeratology in practice. Now, this software is called the ECP software, or you might call it the eye care practitioner software. Within that software is embedded the B-Free lens design. Now, the software platform allows for the initial lens construction. It is a database that you can refer back to and follow the history of a patient. It's an order system, so the submitted orders would automatically be sent to the lab for processing. If you needed consultation support, you can request that, as well as being able to optimize the lens outcomes when the initial fit isn't exactly the way you want it to come out. So this software platform basically aids you through the entire fitting process of orthokeratology. Now, it's not so much a software that you download, it's actually a website that you log into. So regardless of where you are and what you're logging into, as long as you're able to connect to the internet, you're able to get into the software. So that means that you can do that from your cell phone, from a computer at home, a computer at work. You can log in from virtually anywhere. There's no downloading of software, there's no updating of the software, and there's no backups that you need to worry about. It's all done within the cloud. Now, the Health Canada approved range of the B-Free is myopia up to -5 and astigmatism up to 1.5 diopters. So you can consider that a very conventional range of availability. Now, how do you fit the lens? Well, there are many different ways that the B-Free can be determined or initially ordered. From as little as keratometry readings could be used. That isn't recommended, but it's something that could be done in a worst case scenario if the topography data were poor or access to the topographer was challenged one day. Now, if you have topography data, this is the preferred way to build any orthokeratology lens, and the B-Free is no exception. If you happen to have a Medmont Topographer, it's ideally suited to building the B-Free lens and has been validated to be one of the most accurate ways to construct an orthokeratology lens. So many different ways to approach it. We can use K-readings. Ideally, topography data is preferred, and if you happen to have a Medmont Topographer, that's even better. Now, the Medmont Topographer works very much in partnership with the B-Free system. The Medmont Topographer allows us one of the most largest capture areas of data of any instrument on the marketplace. It is also highly accurate. So when that raw data is imported into the ECP software to build a B-Free lens, you're more likely to have a high first fit success rate. Now, the ECP software looks something like this, where we would enter in the patient last name, first name. Date of birth is important because, of course, we're going to design different optics for adults versus children. Then, of course, we want the RX, the size of the cornea, the horizontal visible iris diameter. The K-readings aren't directly used to build the lens if we have topography, but it gives you perspective on how challenging the case is. Of course, a very high central corneal astigmatism will be a much tougher patient than a low central corneal sill. So essentially, we're going to just enter in the patient information, and then we want the topography data. So if you have a topographer that's linked with the with the ECP software, then you can automatically bring that topography, upload it to the site, and the site will pull the information that it needs. The linked topographers at this time are the Medmont, the Oculus, and the Keratron topographers. Now, here we've imported a Medmont topography map into the site. The site has pulled all the information that it needs to construct the initial lens. Now let's just blow up this little window here to have a better understanding. And we can see that the patient's age is 13, and that would suggest to us that we want a myopia controlling optic zone. We want the 5-5 optic zone. The sagittal differential of the eye is relatively low. It's not a very toric peripheral cornea. In other words, there's only 2 microns of sagittal depth difference between the flat and the steep meridians, suggesting that we want a symmetric or non-toric lens. Then it's pulled all of the other data that it requires to generate the lens parameters as well as the visible iris diameter to determine the lens diameter. So we have all the information that's been pulled automatically from the topography. So there's no collection of information required by the user. The software platform just does all the work for you. Now, we talked a second ago about that patient having a 2 micron sagittal differential. In other words, a very symmetric peripheral cornea. Now, when your peripheral cornea has 30 microns or greater of difference between the depth of the eye across the flat and the depth of the eye across the steep, this is where you may benefit from a toric landing. And that's true of corneal GP, single vision and multifocal GP lenses, as well as orthokeratology lenses. And in both these cases, we can see the lens has the appropriate depth across the horizontal in both the corneal GP and the Ortho-K, but vertically we have an inadequate alignment, or the depth isn't appropriate for that increased depth of the steep meridian. Essentially, you have maybe a toric central cornea, but you definitely have a toric peripheral cornea requiring a toric construction of lens. And that's where the B-free creates a real ideal alignment with the eye. Here we have a symmetric B-free on a very toric eye. You see the landing at 3 and 9 o'clock, but of course the vertical meridian showing you that extreme amount of fluid underneath the alignment zone at 12 and 6 o'clock. Now, this might be acceptable for a decent outcome post-wear, but obviously if we create better alignment through this entire alignment zone, the patient may have a better chance of centration, of comfort, and of the appropriate effect across that steep meridian. And that's what the toric creates, creating that ideal alignment 360 degrees around to promote the best possible centration, comfort, and response. Now, in the construction of the lens, you have many different optic zones that the B-free can be built with. A 6.0 optic zone is standard for adults. The 5.5 optic zone standard for adolescents. If we have a much higher RX change that we're shooting for, you can use the smaller optic zone and fit the higher myopia off-label. If you have an adult that you fit in the 6.0 optic zone and aberrations are present, then you can increase the optic zone up to 6.6. So there are 4 optic zones available in the B-free lens, and it depends on patient age as well as RX when you would use one optic zone or the next. You don't have to worry about which is the right one because the B-free software would automatically choose for you. Now, we've got all the information that we need to build that initial lens, the RX, the target, the visible iris diameter, giving us the appropriate lens diameter, as well as the raw topography data that would give us the construction of initial lens that we require. Now, that information is used to build your right and left eyes, or you would construct for both eyes individually, and that would create a truly custom lens for both right and left. Then that order would automatically be submitted to the lab with all the appropriate information: patient name, your account information, and the lens specifications. Now, if you have a Medmont, the system is incredibly efficient and accurate. So if you're beginning orthokeratology, you may want to consider reaching out to your precision or cardinal representative to acquire information about the Medmont Topographer. That instrument makes it so easy to work with the B-free lens, makes it accurate, and will help you to be the most efficient possible. If you don't have a Medmont Topographer, if you happen to have a different instrument, that data can be used to build a lens regardless of if it's linked to the ECP software or not. You just need to pull the information from the topographer that's required to build a lens. Now, what is that information? And of course, to build any contact lens, we need the RX. And ideally, to build a large diameter Ortho-K lens, we want to know the visible iris diameter. The B-free allows us to custom design the appropriate diameter for each eye. Now, K readings aren't directly used in the building of the lens, but as we mentioned earlier, they can be helpful to understand the corneal astigmatism and how easy or challenging your case may be. But what we really want is not the flat K or steep K, it's the apical radius of the eye. Now, apical radius is known in many topographers as RO or R0, which is radius at zero distance from center. It's the curve of the cornea right at the apex. So we want the apical radius that's across the flat meridian as well as the apical radius across the steep meridian. So similar to your thinking in flat K, except we're not looking for the data at 3 millimeters out, we're looking for the radius at the center. Now, to get that information, you set your chord of measure of your topographer at 8 millimeters, and then you click on the flat meridian and record the apical curvature of the eye. In this case, 7.533 is the apical radius of the flat meridian. Then we'll click on the steep button that will give us the steep meridian values, in this case 7.443 millimeters. So now we have the radius of the flat and the radius of the steep. Next, we want the eccentricity. And eccentricity is a measure of the rate of corneal flattening from the center of the cornea to the periphery. In other words, how much does the radius of the eye change from the center to the limbus? And we have here on the flat meridian the rate of corneal flattening on the flat, and then we want the rate of corneal flattening on the steep. So we would go into our topographer's details, set our chord of measure to measure that E value all the way out to 8 millimeters. We'll click on the flat, record the E value of the flat meridian, then click on the steep, record the E value of the steep meridian, and now we have the information from our topographer that we need to build a lens. Now, why do we collect this information? Why bother with apical radius of flat and steep and the eccentricity of flat and steep? And the reason is very simple. Every contact lens is based on building the appropriate height of lens for the height of the eye. If you have the understanding of the depth of the anterior segment, you can build the contact lens. And an Ortho-K lens requires an exceptional level of accuracy. So build the lens from that apical radius and eccentricity, and you're more likely to have higher first fit success and better outcomes for your patient. So the two values for flat and steep meridian help us to build both a symmetric for our very symmetric eyes, as well as a toric when the toricity of the eye is quite high. Now, the last step is to send the order to the lab. Now, if you're unsure of the data, you can just click this box, Request consultation for the order. And that will automatically send the lens parameters and all of your information to the consultant. So click submit, and all the entered information or the uploaded information will be automatically sent to your precision or cardinal consultant to assist you through the process. If you feel like everything has been straightforward, the software has had no trouble building the initial lens parameters, and you don't have any questions, then simply click submit, and that will send the order to the lab. Now, once the lab receives that submission, it'll be processed, it'll be manufactured, and it'll be shipped to you. So the software platform, once you click submit, will automatically send it to the labs, and they'll be able to build the lens with all the information that they require. Now, how do you order lenses? It's really simple. Obviously, we just discussed submitting an order from the ECP software, but you could call in the information to the consultant, or you could email the consultant. There are many ways to order a lens, and really there's no limitations to how you could get that information to us so that we can build that initial lens. Now, once the lens has been ordered and shipped to you, we're going to place it on eye, and we're going to verify the fluorescein pattern. Obviously, we want to see a lens that has the appearance of touch, but really the fluid is so thin we can't make out fluorescein in the center. The Ortho-K lens should never actually touch the central cornea. It should just be thin. Then we want our reservoir of fluid creating our suction force, our alignment zone 360 degrees around, creating good alignment and stability. Then, of course, your edge lift of about a 0.5 millimeter width. So that would be an optimal fluorescein pattern, but really we don't rely heavily on the appearance of fluorescein because Ortho-K lenses work in the closed eye environment. They don't work in the open eye environment. So all we want is to confirm that the lens looks acceptable to dispense. Really, we want to put the patient into the lens and see how it performs during sleep. See how it alters the epithelial shape and therefore the topographical shape, and then we know if the lens is performing as we require, as well as if we need any lens changes. So let's do a post-wear evaluation. Let's do a full slit lamp exam. We can check acuity. Refraction is optional because the topography usually tells you what's happening. Ultimately, what we really want is just to get to the corneal topographer. So if the slit lamp shows negative signs of any concerns, then let's get the patient off to topography. And then the topography tells us many things. Did we get the treatment right? Do we have the bullseye response with that perfect centration and good myopic reduction? Did we steepen the central cornea up, creating what's called the central island? Did we have a high riding lens, creating a treatment zone decentered high and creating this inferior smile? This high riding topography is known as the Smiley face. Or did we have the blue treatment zone riding low, creating the frown of a inferior displaced lens, or the Frowny face outcome? So really, topography tells us everything about the outcome of orthokeratology treatment. Now here is the ideal bullseye topography, where you see a blue treatment zone well centered to the black pupil margin and visual axis. This is what we desire in orthokeratology treatment, centering that treatment area, providing the patient the best possible vision and the reduction in myopia that we desire. Now, if that effect had left the patient slightly undercorrected or slightly overcorrected, then what do we do? How do you alter the lens parameters? And it really becomes very simple. We're going to upload the topography to the ECP software and compare. Here is our outcome. What does that topography look most like? Does it look like the bullseye, the central island, the smiley face, the frowny face, or lateral decentration? In this case, clearly our outcome topography looks identical or very similar to the bullseye in the gallery of options: bullseye, central island, smiley face, frowny face, decentration. So we have a bullseye topography, but what if we have an under or over correction? How do we alter the lens parameters? Well, let's go to the next screen, and under refraction change, we can enter that the patient was short in treatment of -1. So the software will automatically alter the parameters of the lens to give you that extra hydraulic force and squeeze out the extra minus that we require. So one doesn't have to be an expert at orthokeratology treatment. One doesn't have to be an expert in understanding lens construction and modifications. The ECP software will help us through this process to optimize the fit. Now, what do you do when you have one of these outcomes? And this happens in Ortho-K approximately 80% of the time. With most designs, you get the bullseye. But what happens those 20% of the time when you don't get the bullseye, when you have the high-riding smiley face or the tight-fitting central steepening of the central island, when you have the low-riding treatment zone of the frowny face? How do you modify the lens? Well, let's go back to the topography, and here is our central island. Notice the blue treatment zone decentered, slightly low in relationship to the black pupil. Then we see the island in the middle of the blue lake, and that's telling us that we have central corneal steepening rather than central corneal flattening. So our lens was too far off the surface of the eye, and that's creating epithelial steepening rather than epithelial flattening. So let's upload that topography. If you have a Medmont, an Oculus, or a Scout, you can upload the topography to the site, and we can look for which of the topographical outcomes in the gallery is most like our actual topography here. And you would say that it's definitely central island as an outcome. Is it mild? Do we need a small change? Is it moderate? Do we need a kind of significant change? Let's call it an average change. Or do we have a severe outcome? Is it extreme as a central island? Now, when in doubt, choose moderate. That's the one in the middle that creates the significant jump in parameters. In this case, I think this topography looks very much like a moderate central island. It's not a mild with a tiny amount of central steepening. It's not a severe with a significant inferior displacement. It's somewhere in the middle. And again, when in doubt, always choose the moderate. So we can alter the parameters of the lens with that moderate response. The software will do all the complicated work to rebuild the lens, to reduce the sagittal depth, and to loosen up the alignment zone to create the bullseye outcome that we desire. Now, what about here? Here, this is the outcome that we see with great frequency when it's not a bullseye. And that's where the blue treatment zone appears decentered in relationship with the visual axis and the pupil. You'll notice that blue treatment zone riding high in relationship with the pupil and visual axis, giving us a paracentral steepening inside the pupil in this case. Now, there's always paracentral steepening, but the question is it radically decentered? And you can determine that by the center of the blue treatment zone. So this is what you'd call your smiley face outcome. It's a high riding lens. It's a loose fitting lens. So let's go back to the ECP software. Let's upload our Medmont topography. We notice a high decentered treatment area, a smile intersecting the inferior pupil. It's looking not like a mild, maybe a severe, maybe a moderate, or maybe a severe. It's one or the other in here. Again, if I'm not sure, moderate creates that significant jump. If I'm thinking this is severely high, if the patient was very uncomfortable with wear last night, then I might select the severe outcome. Generally, it's going to be moderate, as we said before. Now, the last outcome, the low riding treatment zone, where we see the blue decentered low in relationship with the visual axis in the center and the black circle of the pupil. We notice the treatment area riding low, giving us that paracentral steepening, that frowny face intersecting the pupil margin. Obviously, our low riding frowny face outcome. We'll go back to the ECP software. We'll upload our topography to the site. Then we'll compare our topographical outcome against the gallery of mild, moderate, and severe outcomes. This one looks very much like a moderate, so we'll select that. The software will rebuild the lens. Now, what happens if you don't have the Medmont? Then all you're going to do is look at your topography software and then refer over to the ECP software and look at the gallery and decide, does your topographer show you the mild, the moderate, or the severe? Now, the B-free lens is a platform that allows for that myopia up to 5 diopters and astigmatism up to 1.5 diopters. It allows for both symmetric and toric construction, as well as multiple optic zone sizes to create the aberrations that we desire, or the lack of aberrations for adults. So there are many options available in the construction of this lens that makes it truly unique. For instance, the toricity of the lens is available in 1 micron steps. That's exceptionally tight for toricity, allowing for a very customized lens for each and every eye to create the best lens to cornea relationship. Having the ability to create a 5.0 for higher minus, a 5.5 optic zone for our adolescents for that increase in aberrations, creating a 6 millimeter optic zone for our adults, but also having the larger 6.6 optic zone when we want to reduce aberrations in our adults. So many different options with the B-free design. One of the most powerful things may be this ability to control the treatment zone size with the variable optic zone, and being able to increase the aberrations with the smaller optic zones and decrease the aberrations with the larger optic zones is something very important in the building of the B-free for specific patients. So it's not a one size or one construction fits all. It's very much designed specifically for each patient. The B-free lens is an entire system where you have lens, you have software, and you have the support of the consultants. So for the neophyte user, this is a platform that makes it possible for you to be accurate, to be efficient, even with very limited knowledge in Orthok. But for the experienced user, the customization available with the ECP software and its ability to build lenses specific for toricity, specific for the age of the patient, and specific for the myopia of the patient makes it a very valuable choice for the very experienced orthokeratologist as well. There's so many ways you can fit the B-free lens. As little as K readings can be used. Ideally, topography data is used in the construction, and if you have the Medmont, you have a ability to have an exceptionally high first fit success rate. The practitioner can be wholly involved in the process of building the lenses, or you could train your technician to upload the maps and to determine that first lens, because so much is reliant on the ECP software. Or if you prefer, you can just send all the information to your consultant, either by phone, by email, and that way you have many different options for building the lens, depending on your schedule. Sometimes you're going to be exceptionally busy. You won't have the time to upload the maps. Maybe you want to just email them off to the consultant. But ideally, if you train one of your technicians to take good topographies, to learn how to use the ECP site, and they can do much of this work for you. Because this is a software reliant system, it means that even the most novice of practitioners and novice of orthokeratologists can be as successful as some of the most experienced. There are multiple ways you can order the lens, as we discussed. The consultant can help, but either by phone, by email, or through the ECP software. So you have many ways to reach out to the Precision and Cardinal team. What's important to begin is that you become B-free certified. So go to the Precision or Cardinal website, ptsoptics.com, and go maneuver to the education and certification with the B-free lens. That will allow you to finish the certification process, get access to the ECP platform, and then you're able to order lenses from the lab. So start with the certification for the B-free, and then you're ready to order lenses. From the website, you can download the B-free certification test. Fill in all your practitioner and your practice information. Then when the questions come up during the certification video, you're ready to answer the 20 multiple choice questions. Then submit your certification test to the emails noted below. It'll be marked. You will be informed of your certification success. Then you will be able to get access to the ECP software and order the B-free lens. So this B-free lens is very much a technological advance in Ortho-K, using topography data to build the lens, constructing the lenses in a 3D space, having the ability to customize in an incredible way the symmetric versus toric and how much toricity do you actually need, being able to customize the optic zone size to build the appropriate aberrations that you need for individual patients based on age and RX, and having the platform to do most of this work for you, as well as problem solve when the outcomes need some modification. So for more information on the B-free system, go to the website, ptsoptics.com. That's where you can get your certification. Or if you have questions about the system itself, info@ptsoptics for Precision, or info@Cardinal Contact Lens for Cardinal in Ontario. Thank you very much for your interest in the B-free orthokeratology lens.